All right. Well, welcome everyone to this very special evening edition of our Waypoint Talks series. This evening's presentation is on improving approaches to end intimate partner violence. As you're starting to join us, we would encourage you to please use the chat to share what city or organization you're joining us from today. As a reminder to everyone that is joining us, we are going to record this session for those who were unable to join us this evening. And another reminder is, if you don't mind, as through the course of the evening's presentation, if you have any questions that you would like to pose to either of our speakers, to please use the Q&A function at the lower bar of your space. We will be moderating and integrating these questions throughout this evening's presentation. So without further ado, I'm going to turn things over to Dr. Nadia Sanderji, who will start us off this evening.
Wonderful. Thanks so much, Jessica. And it's fantastic to be together with you this evening. Thanks so much to everyone for joining. Some of you know me already, but for those who don't, I'm Dr. Nadia Sanderji. I am the president and CEO at Waypoint. It's a great privilege to say so and to be in the role. I am a psychiatrist by training and practiced for many years, also having a clinical academic practice, and I'm an associate professor at the University of Toronto Department of Psychiatry. I've had long-standing interest in integrated and collaborative mental health care, really looking at how the whole health system and social service system can be working together to better serve people, which sort of connects up in an interesting way to the work that Dr. Hilton's going to be talking about this evening. As well, and an interest in urgent, emergent, and crisis mental health care, and again, sort of working across the full continuum to meet the needs of communities and regions. And more broadly, clinical innovation, quality improvement, system planning, and governance. So that's just a little bit about me, but more importantly, very pleased and thrilled to introduce Dr. Zoe Hilton. Dr. Hilton is the fairly newly appointed research chair in forensic mental health at Waypoint, and she's a full professor of psychiatry in the Temerty Faculty of Medicine at the University of Toronto. She's also a fellow of the Canadian Psychological Association. And since joining Waypoint over 30 years ago, she has been both a frontline clinician and a full-time researcher. So really bringing that full kind of breadth and depth of expertise that we're going to hear from this evening. She's conducted very influential research in the areas of domestic violence, risk assessment, risk communication, and more recently, the physical health and psychological well-being of both patients and staff at a psychiatric hospital. She's the lead of the research team that created the ODARA, which is the Ontario Domestic Assault Risk Assessment, and we'll be hearing more about that this evening as well, I hope. And she's the principal investigator on SSHRC-funded research to examine standardized risk assessment and coercive control in domestic violence. So a lot of very interesting and super important work. Congratulations, Zoe, on all of that, and we cannot wait to learn more about your work. I'm going to start off with a few questions that I have for you, and it's such a unique opportunity for us to sit down and chat in this way. I'm going to remind folks, as Jessica mentioned earlier, please feel free to drop your own questions into the Q&A section or the chat. You'll see the icons for both of those at the bottom of your screen, and I'll keep an eye on those and kind of integrate them into the conversation. We'll certainly make sure that there's time for other questions at the end as well. So with 53 minutes, here we go. All right, so Zoe, why don't you tell us a little bit about what inspired you to undertake research in this area?
Well, sure. First of all, thank you for the kind introduction, Nadia. It's a pleasure to be with you and with everybody here tonight. So yeah, there's a few things on my journey that really inspired me to undertake research in intimate partner violence. And I would say that's starting with when I was a graduate student. when there was a lot of attention to how bad the criminal justice system was at responding to violence against women. Even though, sexual assault, domestic violence, family violence, these have been criminal offenses for a long time. I was hearing that when women were assaulted, when they went to the police, they were being ignored, they were being bullied, or they were being blamed for the violence against them. And I actually at that time did some ride-alongs with police, and they were saying they didn't want to have to respond to domestic violence at all. And I'd be arguing with them from my point of view, but I think we were both stuck in our positions. And over time, I've realized that, yes, some of the reaction at the time was the sexist attitudes of the time, but there was also a lot of frustration for police for not having an understanding of intimate partner violence, not having the language to understand it, not having the tools to assess the situation or the backup from the courts if they press charges. But what happened next was then I heard about how the police in Ontario were trying different approaches. And I wanted to come here and learn about that and do research that contributes to that. And I've been very fortunate over the past 30 years or so to be able to partner with policing organizations and work on developing risk assessment tools with them.
That's fantastic. What an inspiring way to find a problem and work with others to tackle it. And I get the sense that the ODARA is, I think, one of those tools that you've worked collaboratively to develop and implement. I think we'd love to hear more about that tool and how it plays a role in preventing intimate partner violence.
Mm-hmm. Well, so the work for the ODARA was conducted through a partnership, a long ongoing partnership with the Ontario Provincial Police. And what we did was, using information that would be available to police, develop a brief assessment tool that enables police or other first responders to identify the highest risk cases of intimate partner violence, so the cases that are most likely to lead to violence again in the future. And we developed the ODARA tool that found that our original research was all with men. We've subsequently done research with women as well, but we found that men with higher ODARA scores are more likely to assault a partner again. They reoffend sooner and they commit more severe assaults. So having a tool like the ODARA means that police officers can be aware of the risks faced in a domestic situation, and it can help them decide whether it's a situation where the perpetrator needs to be held in custody for a bail hearing, or can help a court decide if this is someone who needs to be kept in custody or they can be supervised in the community. Because, of course, not everybody who commits an offense is going to be put in jail or prison or even go through the forensic system. And those spots in jail need to be used for the most risky individuals in order to get the most benefit of preventing violence. So to help prevent intimate partner violence, you need to be able to identify who's most at risk of assaulting someone and use all the resources wisely, whether it's jail spots, whether it's places in treatment. There are intimate partner violence treatment programs across our community, but always a limited number of openings. And the ODARA can help treatment providers identify who's most at risk of assaulting their partner and doing so relatively soon. So it can be a tool for deciding who gets to the top of the waiting list if there's a waiting list. And it's also a tool that can be used by the people who've been assaulted by their partner. They want to know what risks they might face of being assaulted again in that relationship, and it can help them make decisions about safety planning for themselves and their children. So all these different ways that we already have for intimate partner violence prevention, all these different ways and resources can be put to more effective use by using the ODARA to assess risk.
Thanks. So there's I think you've highlighted a really important aspect of sort of risk stratification. There's the high risk and low risk, and how I'm going to use my medical jargon for a moment, but essentially people are triaged into the right kind of setting or service for them based on that risk level. But I think you were kind of also maybe getting at a bit of communication, like how how level of risk gets communicated among different individuals who need to have that information and within sort of institutions and systems. Could you maybe say a little bit more, Dr. Hilton, about kind of how communication happens in these scenarios? It's so interesting to get a glimpse kind of behind the scenes, and would love to just better understand that.
Well, of course, communication about risk is really important, because if you assess risk and don't share the results with anyone, it's not going to help prevent intimate partner violence at all. And if you assess risk but can't effectively communicate your understanding of risk, then that doesn't help at all, can't help either, because often in these situations, we have different understandings of what risk is. And even when we talk about risk, I might say something's high risk, and you might say, well, that's low risk to me. So being stuck with just our own impressions, or having to use this language like low risk and high risk, it doesn't help us communicate risk effectively, so that we can coordinate our efforts and identify what are the cases that we all need to be paying the most attention to. So the ODARA helps with that communication by providing scores and risk categories. So an example would be, say a man scored 7 on the ODARA. You can say that this is in the highest category of risk for intimate partner violence reoffending, and men score 7 have a 70% risk of a new police report of assaulting their partner in the future. So it's very specific information, and we can all understand numbers. We all sort of understand what 70% is or what 30% is. And that communication clicks more than if we're relying on saying things like low risk or medium risk or high risk.
Thanks, that's really helpful. Yeah, as you were talking about, the other thing that was on my mind is introducing this is quite a significant change, I'm sure, in the day-to-day work of law enforcement. And I'm just thinking about kind of the magnitude of sort of change management and involved in something of this level. I'm curious if you can tell us a bit more about kind of whether and how law enforcement agencies have kind of how widely has this been adopted and implemented, and were there significant barriers to that, or sort of have they really embraced it? What's that process been like of translating research into practice?
Well, the ODARA was actually really widely embraced in law enforcement and among other practitioners as well. Police organizations were already trying to assess risk and already had some rudimentary tools, lists of risk factors, and so on. And what the ODARA did was we did the research that showed what were the most important risk factors. If you just wanted to make a short list of the risk factors, the items that are on the ODARA are those risk factors. And so it kind of made that process of risk assessment easier and clearer. And there are clear instructions for the ODARA: what's included, what's not included, how do you count this, what do you do with that, and so on. And so it was fairly readily embraced in the policing community. It's now embedded in the domestic violence risk management investigative tools that police use throughout Ontario. And it's been adopted in policing, corrections, and treatment across Canada and outside of Canada as well. I think at the time that we published the ODARA, we were ready to start sharing the ODARA, there really was a need, a recognition, a desire to have tools to make the risk assessment easier and evidence-based and easy to communicate. And I think that need and desire is still out there.
Thanks, Zoe. It sounds like there's been a huge appetite for this. There's a couple of questions in the chat. One, and I'm going to go to the second one first because it relates to exactly this. So wondering, is there a policy or requirement for the police to administer the ODARA when they're investigating a complaint of intimate partner violence? And how do they, can you just sort of describe for us a little bit more, how do they then use the score?
Well, the ODARA items in Ontario, they're embedded in the tools that police officers use. So there's an expectation that those particular tools and forms are used when officers are investigating an eligible offense, a domestic violence offense. And how that gets used then depends on what's happening with the case afterwards. In some cases elsewhere in Canada, for example, the ODARA is presented at pre-trial or pre-sentencing decisions, where courts in some areas are used to hearing about it and expecting to hearing about it, so it will be reported or read in. The ODARA information can also be used to inform victim survivors about the risk that they may face in that relationship, and that can come from the police or it can come via victim services. People can also hear about the ODARA by going through an assessment interview with a counselor or a transition home worker. So they get that information as well to support their safety decisions. So yes, I would say in Ontario, police are expected to use it because it's part of the tools and forms that they use all the time. And then there's different levels of requirement or practice across the country.
Got it, thanks. And then here's another really interesting one. So we've been talking so far about this tool being adopted and implemented in law enforcement. And there's a question about whether women's shelters are utilizing the ODARA tool. Should clinicians be using it? Should it be used sort of more widely? Could it even be a self-report tool? So thinking about some other applications or different potential participants to adopt it. Any thoughts on that?
Yes, of course. When we created the ODARA and shared the ODARA initially, we really wanted it to be used what we call across sectors. So in criminal justice, in health, mental health, victim service, victim anti-violence, victim advocacy. And that was part of the impetus behind making the risk communication piece very clear and consistent and not relying on judgment, because what somebody sees in law enforcement might, kind of set their perception of high or low risk very differently from what somebody might see in healthcare, for example. So that communication piece and the simplicity of using the ODARA is something that I actually hope would help it be used across different sectors. One of the first sectors actually to use the ODARA in Ontario was child protection, because exposure to domestic violence can be seen as potential harm to the children. And so Child Protection Services adopted the ODARA into their very comprehensive approach to assessing risk in families. Certainly used in treatment centers, it can be used in shelters. In fact, some of the first research we did after we developed the ODARA was working with shelters in our area and with sexual assault and domestic assault clinics based in hospitals, who gave us a lot of feedback about how we should do, again, the communication piece to make that easier. In terms of a self-report tool, that's more challenging because some of the risk factors that are on the ODARA really come from a criminal justice history. So when the ODARA is used as a victim survivor interview in healthcare or in shelters, it can be scored based on the information that the person who's been abused is aware of, but they might not be aware of the full criminal history of the person who's assaulted them. They might not be aware, have they been involved with the police before? Have they been on a probation or parole before and violated that probation? They might not be fully aware of the risk factors in their relationship. So as a self-report tool, it's more challenging, but certainly within the context of victim support services, the ODARA is available as an interview, and the information can, the victim survivor can share the information that they know, and that can be shared back with them in the form of a risk score.
Thanks. Now, building on that question about the potential for clinicians to use it, Zoe, there's a question kind of in a similar vein. And from my own training in medical school, I feel like I might know part of the answer to this, but I'd love to hear your thoughts. How familiar are I think this might be meant to be primary care providers, Steve, I hope I got that right, versus primary caregivers, but how familiar are they with this tool when they suspect intimate partner or family violence? And is this the right tool? Are there maybe other tools that are used for screening in those circumstances? Any thoughts, Zoe, on sort of how we would go about assessing and communicating about risk in different settings?
Yes, a good question, because actually primary care is an area that we've been less able to reach with the ODAR. You know, we've had partnerships with policing and criminal justice. We've had partnerships with community services for victim survivors, and in healthcare and so on. Primary healthcare, though, has been one of those areas that we haven't reached as much. And in primary healthcare, there's maybe a couple of issues. If the healthcare practitioner is concerned that intimate partner violence might be an issue for their patient, there are screening processes that they can go through with the patient to get at whether they're being hurt by anybody that they live with, whether they're afraid, whether that person is limiting what they're able to do, and so on. So that screening process is perhaps more of an issue in primary healthcare. And there's been some good research done by other researchers looking at what's the best way to do that screening. And then that information can also inform us, of course, in mental health care as well. The risk assessment piece comes in with the ODARA when you're concerned about somebody who's already been assaulted and what is the risk that they might be assaulted again in that relationship, or somebody has committed an intimate partner violence offense and you need to assess the likelihood that they may commit another offense in the future. And so that's where the risk assessment comes in, and that tends to be in these other contexts, you know, in criminal justice, in forensic healthcare, and so on.
Thanks. Yeah, absolutely. And I'm remembering sort of being trained to kind of ask something like, you know, do you feel safe at home? Or there's other evidence-based sort of brief questionnaires. We designed like a little pocket card back in the day when doctors carried around those things to sort of remind them about what the questions might be. But thank you for helping make that distinction between sort of screening for the possibility versus sort of assessing the risk once an event has already occurred, at least one. There's a couple more great questions, and I still have a few more too, but let's keep going with these because they're really interesting. So another question that came through relates to the role of gender, Dr. Hilton. And so does the ODARA kind of apply in terms of risk analysis, regardless of gender in the intimate partner relationship, same-sex partners? Does a particular gender increase or decrease the risk?
Mm-hmm. Well, I can say that the ODARA has been really well validated for men who assault women, and there are some validation studies for women who assault men or women. It's not really been teased out the differences between people in same-sex relationships and people in relationships with other gendered individuals. And I will also say that other genders have not really been attended to in the research so far on intimate partner violence risk assessment. That is something that we are looking at in a current project, which we call the CELIA Intimate Partner Violence Project, where we're examining risk assessment regardless of gender, so in gender inclusive and sexually inclusive populations. So it's definitely an understudied area, and but we're working on that.
That's great. Well, we can't wait to hear more about the results of that. There is a really interesting question that I'm just going to actually read it how it is. It's very beautifully expressed, and I might break it up into a couple of questions. So psychologist Jonathan Haidt, in his most recent book, spent a good deal of his book talking about the changes in male youth, and in particular, their withdrawal from society into the internet, including high game use and porn use. And given these trends, could you picture changes being needed in the next few years to your assessment tool? Or do you see the factors in the tool being highly stable across a changing society?
Well, one thing that I would say about that, the change in behavior and the focus on online activities and so on, is that we've seen the emergence of cyberbullying. I think people are familiar with that, but there's also cyber-based coercive control, threats, intimidation, as well as partners monitoring and tracking, sometimes secretively, their partner's activity on social media or their contact with family, going through their phone, that kind of thing. And alongside that, we've seen much more awareness of the whole picture of coercive control. So intimate partner violence, there can be physical violence, but the broader picture of abuse can be a lot of behaviors that are not physically assaultive, but intimidate and isolate and restrict the partner and make it difficult for the partner to leave the relationship if they want to leave an abusive relationship. Sometimes even difficult to trust their own instincts about what's going on in that relationship and what they're experiencing. So partly that all that cyber activity has increased awareness of coercive control, and that is a huge issue now, because for some time there's been a bill going through Parliament to make coercive control a criminal offence, and it looks like it will be criminalised very soon now. So will it make a difference to the ODARA? Well, part of the research that we're doing right now is looking at all forms of coercive control, including technology-facilitated coercive control. And we'll be seeing how strong a risk factor that is and whether it's something that we should be adding to the ODARA.
That really resonates with me. I must say, now that the pandemic is over and people are starting to travel again, I recently got an Apple AirTag, and to put it in my case, and I was so taken aback because as soon as I activated it, this warning comes up saying that using it to track an individual without their knowledge is illegal in many jurisdictions. And anyway, it was just very startling because, of course, that was the last thing on my mind. But it just makes you realize how we have to keep pace with technology from a public safety perspective. I want to come back to well, no one really wants to go back to thinking about the pandemic, but let's do it for a moment. Can you tell us a bit about whether intimate partner violence changed during the pandemic, either in terms of its prevalence or its nature, and kind of in a similar vein, then does that have any implications for the tools or more broadly?
Mm-hmm. Well, there's actually quite a number of studies that showed that intimate partner violence increased during the pandemic. In fact, all forms of family violence, child abuse, and so on seemed to increase during the pandemic. And it's not just that it was getting more severe or more frequent, but it seemed that more people were exposed to intimate partner violence than had been before. And partly the lockdown situations probably made it worse because people couldn't, they weren't free to leave or escape or just get time out from that relationship. And of course, the mental health and the stress and so on perhaps impacted that as well. it's not clear how that might have changed risks for intimate partner violence. And in fact, one of the things that we're conducting research on right now is looking at how prevalent various risk factors were before COVID and during COVID and since COVID, and looking at how risks have changed and whether we should be assessing risk differently afterwards, even now lockdowns are over. How is that impacting risk assessment? I don't know what the answer to that is yet, but that's definitely something that we are, again, working on.
So that's like taking it from a kind of individual risk level in a way to kind of thinking about like population level risk, thinking about kind of prevalence and what that means for the systems that need to be activated in these scenarios and their kind of capacity. One of the questions relates to courts being backlogged. And, you know, we hear about that in the news, and we certainly hear about it in our work at Waypoint. How can we avoid having intimate partner violence cases being dismissed? And Terry's got a very detailed knowledge of this area, and she's wondering about Section 11B of the Charter of Rights. And so really kind of it also comes down to how can we as members of the public best advocate for justice?
There's so many levels to that. In terms of risk assessment, one way the ODARA can help with that is by identifying the level of risk in an individual case. And sometimes people are surprised to see what the risk factors are and what risk factors are present in a particular case. And then perhaps they may attend to it more seriously. Making people more aware of what the risk factors are, making people more aware of, you know, the potential for harm, not just for the person who's being abused, but also for the children and so on. I think we've seen some very awful cases, even in Ontario, of how the children have been used to get at the mother, say. And I think it is being taken seriously, more seriously by the courts now than it was in the past, and with recent legislative changes requiring education for judges and so on. I think bit by bit we're making inroads. Certainly I see so much change and improvement over the 35 years that I've been working in this field. But I think that advocacy, tireless advocacy, is still needed.
Well, that's a hopeful note in a really sad and difficult area. Dr. Hilton, you mentioned way back towards the beginning of this conversation about folks getting directed into treatment for intimate partner violence. Which also seems like a really important part of the solution. Most of us, I think, probably don't know what is involved really in treatment of intimate partner violence, and I think it would be really interesting and helpful to know more about what's involved. And then maybe a part two of my question would be knowing how difficult it is to get access to, like, some of the services that, you know, we deliver, mental health and addictions related care, for example, and the capacity constraints that exist there. Is that also true for treatment for intimate partner violence? Is this an area where we also have real shortages and unmet needs? So kind of part A is what are we talking about when we think about treatment for IPV? And then part B is realistically speaking, can people access it?
Well, I can answer part B more straightforwardly to begin with, that we have programs in Ontario, such as the PAR Program Partner Abuse Response Program, and some programs designed specifically for and with Indigenous communities. The way people get access to them is to be charged with intimate partner violence and be referred or mandated, required through their probation order, whatever it may be, and that's how they get into those treatment programs. I'm not as familiar with treatment programs offered privately and so on, but there tend to be fairly standard modules or approaches to intimate partner violence treatment. Treatment has gone through a lot of changes over the decades. Initially, there was a lot of focus on recognizing power and control imbalances in a relationship, letting individuals, or encouraging individuals who have perpetrated violence be more aware of those imbalances and try to redress them, looking at their attitudes and so on. Over time, people started using more of the kinds of treatments that are found to be evidence-based treatments for other psychological problems or other behavioral problems, such as cognitive behavior therapy, and bringing those methods into intimate partner violence treatment. Another model that is increasingly being recognized in intimate partner violence treatment is coming from what's effective service in correctional settings and focusing on what's called criminogenic needs, so treatment needs that are related to criminal offending. And these can include things like substance abuse and marital relationship problems and so on. And research is finding actually that the more that treatments use these principles from correctional service, the more effective they are. At the same time, I'm seeing now with coercive control being an issue of manipulating that balance and control in the relationship. We still need to keep those aspects in intimate partner violence treatment, especially where somebody has been perpetrating coercive control.
Thanks. That's it's good to understand sort of what exists and what it involves. You mentioned, so yeah, I wasn't. You mentioned about criminogenic. Say it again.
Criminogenic, yes.
Yes, and in particular, you mentioned substance use. I'm wondering if you could comment on the kind of interplay between substance use and intimate partner violence, and what does that mean for kind of how we assess and address risk?
So substance use is a risk factor for violence. It's a risk factor for intimate partner violence. It's a tricky one to deal with in a treatment setting because there's the potential for somebody to say, well, I couldn't control what I was doing because I was drinking or because I was using drugs. And so it's important to treat both the intimate partner violence and the substance use if there is substance use going on. So it has been controversial in the past because of that tendency to use substance use as an excuse. But I think as more research is happening, people are seeing that this is a risk factor that, regardless of what we think of its role as a cause or excuse or whatever it may be, it's still a problem that needs treating. And the evidence would suggest that if substance use is treated, that can improve the risk of intimate partner violence.
Oh, interesting, because in the work that we do, at Waypoint and elsewhere, we think of treating concurrent disorders in terms of the co-occurrence of substance use and mental illness, like depression, anxiety, schizophrenia, et cetera. But you're kind of talking about a different co-occurrence of substance use and intimate partner violence, also requiring maybe some adaptations to the approach in order to effectively really treat both. There's a question in the chat that takes us back a little bit to the tool, so I want to go there, and then I'm hoping we can take a few minutes to kind of look ahead to the future and what comes next. But Steve was asking whether the tool is applicable to uncover risk of elder abuse in families. And so I might make that a little more general, Dr. Hilton, and think about, is it applicable to other forms of other, risk of violence beyond, in all its different forms beyond intimate partner violence?
So the ODARA can apply to intimate partner violence that occurs between partners of an older age. It's also been found to be associated with child abuse. So where there's intimate partner violence in a home and there's children, the children might also be at elevated risk and vice versa. And we found that higher scores on the ODARA are also associated with assaulting the children. In terms of elder abuse, so a child or a caregiver abusing an older person, a parent or somebody in their care, it hasn't been tested in that situation. And again, I would say if you wanted to uncover something like elder abuse, then stepping into it with screening questions would be appropriate for a first step.
Thanks for that. So, when I think about kind of the totality of what we've been talking about, there's identification of risk, there's communicating about risk, there's navigation into treatment of risk, there's preventative factors, thinking about other co-occurring circumstances. Like kind of all of this hopefully really moves the needle on some bigger kind of outcomes. And I wonder if you want to tell us a little bit about kind of if all of these things were working together in a really good way, sort of, what is the end result? When I think about, the people that we serve in the, mental health and addiction sector, and how many of them have experienced trauma, including, but not only intimate partner violence, like, what does this mean big picture for, for the people for the populations and people that we're trying to serve?
Mm-hmm. I'm glad you're asking specifically about people in the mental health system, people facing mental health problems, because it can be so strongly related to intimate partner violence and that coercive control. Intimate partner violence isn't just about the cuts and bruises and broken bones, it's about the other effects too. Experiencing intimate partner violence is related to mental health problems like depression, anxiety, post-traumatic disorder, and it affects people's social well-being. We know now, I think, that social connectedness is really important for people's mental health. And one thing that intimate partner violence does is cut people off from their social supports. So you mentioned in an ideal world, and if things were working ideally, we could all be on the same page in the criminal justice system, in the health system, mental health, social services, community victim support services, and so on, so that there's no gaps in our service. I think that people who are in the mental health system are more likely to have experienced intimate partner violence, they're more likely to be experiencing the harmful effects of it, but they may be some of the last people to be able to benefit from the research and the knowledge base that we have. And I would say that's especially true among people who are in the forensic mental health system, who are marginalized. They may be marginalized because of gender, but also because of mental illness, being involved in the criminal justice system, being hospitalized, and so on. And they tend to be the last people that we reach. So ideally, we would be bringing the lived experience of people in the mental health system into our research as well. And that is something that we're actually trying to work on now, starting to do what's called lived experience co-research. So those people who research is about, who we want research to benefit, need to be involved in determining what are the research priorities, designing the research questions and the studies, and determining what we're looking at and what we do with the findings. So we're working on some of that right now, and including people within our forensic mental health services, and together identifying what are some of the treatment needs there. I've gone off on a bit of an area of interest for me. I'm not sure if I've answered your question there, Nadia.
No, that's great. You did, and then some. Actually, you went where I was going to go next, which is to understand a little bit more about what comes next for this very exciting program of research. And you're talking about some kind of very innovative approaches, engaging people with lived experience. So I wanted to just invite you to comment if there was more that you wanted to say about what comes next for the future of your research, or what comes next in terms of your vision for forensic mental health research more broadly as our research chair.
Well, yes, I think what comes next, both for intimate partner violence risk assessment research and forensic mental health research alike, is a big focus on making sure that we bring the lens of equity, diversity, inclusiveness, and indigeneity into the research. And so doing the lived experience co-research is part of that, because it empowers and enhances more voices in the research activity, and we're developing frameworks and opportunities for that to happen now. And this focus also involves building our partnerships with Indigenous partners and organizations that serve racialized communities. And that can include continuing to study coercive control and how it might be expressed differently in different cultural contexts. So working on ways to improve the what we call EDII lens, more inclusiveness, equity, diversity. We have ongoing projects and lots more to do in this area.
That is very cool. You were talking a little bit more about populations that are marginalized, and many times marginalized by virtue of different conditions, including their mental illness, having come into contact with the criminal justice system, and many other factors. It seems to me that maybe in a more general sense, stigma around mental illness and has been shifting at least a little bit over time, with a greater willingness to reach out and seek help, maybe especially among those who are younger. But there's many other conditions, that sort of factors that you identified, that also drive stigma. And so as we sort of get closer to the end of our session, I want to invite you to comment if you feel that there is anything that participants in the session can sort of take away in terms of how we all can contribute to reducing stigma, whether it be related to mental illness, whether it be related to justice system involvement, whether it be related to IPV. We know there's a lot of stigma for those who experience IPV. Anything you want to share about how we personally can contribute to shifting that narrative?
I think talking about it like this really helps to shift that, really helps open things up. Participating in a webinar, learning new things like this makes each of us more aware of the problems, the issues, can help us be more aware of other people's perspectives on the issues, and opening up that conversation. For example, if you were concerned that somebody might be in a situation where they could be experiencing intimate partner violence, or even perpetrating it, being willing to have that conversation and just ask gentle questions about it. If somebody's not ready to talk about it, then they may be not ready to talk about it, but they might remember when they are ready that you were open to talking about it. And that helps relieve some of the stigma around it. It helps put things that out in the open, that you can talk about what you're going through without it being judged, or you're not going to be blamed or asked, what did you do, or anything like that. I just think talking about what are some of the risk factors, what are some of the situations where intimate partner violence happens, and what we can all do to help with intimate partner violence prevention. I think that all goes towards reducing the stigma.
Thank you so much. It seems like it's really about creating those safe spaces for conversations to happen whenever and however and wherever the time is right for the person who's having that experience. We're just about at the end, Dr. Hilton. I guess what I would ask you to share with us by way of a wrap up of this incredibly inspiring conversation about your research, is there one thing that you could share that kind of, you know, signals to us that there's a hope for a better future, which is really kind of what this is all about? And then we'll go to Jessica to wrap us up and share a link to the Celia project that you're leading in the chat and so on. But before we go there, just tell us what gives you and what can give us hope for a better future in this area.
I think there's plenty of reason to hope for a better future. I've been working in this field for 35 years and I have seen so much change. People no longer ask, at least I don't hear this question, people no longer seem to ask, well, if she's being abused, why doesn't she just leave? I think now we understand the forces that make it difficult for a person who's being abused to protect themselves. So that's been a major shift. I mentioned at the beginning how difficult it was to discuss intimate partner violence with police officers. And now, over the past many years of my career, I have seen police organizations really want to do evidence-based policing and really want to make sure they're assessing risk and providing supports and not letting anybody fall through the gaps. And I also see this shift in mental health services as well. We're so aware of the fact that many people who are in our mental health system or using mental health services are experiencing intimate partner violence and the wide-ranging effects that can have on them, and the opportunities that we have to be part of increasing their access to supports and services that they need. So I have a big sense of hope, and I hope that others can share that as well.
Wow, thank you so much. That is just incredibly moving, and I am so grateful to you for not only all the research that you've been doing and advocacy over decades to really contribute to the transformation that you're describing, but also very grateful for the time you took with us this evening to share about your work and answer the many questions we threw your way in such a just eloquent fashion. Your knowledge and your passion really shine through, and it makes me so proud and grateful to have you at Waypoint and at the Research Institute. And thanks to those who have shared some kind comments with us in the chat as well. With that, I will turn things back to Jessica, and just with my personal thanks to everyone who joined this evening.
Thank you so much, Dr. Sundarji and Dr. Hilton. And thank you to everyone who chose to come and spend your evening with us tonight. I hope you are coming away with some new information. And by all means, if there are additional questions or you would like to connect with Dr. Hilton and her team, I would definitely encourage you to reach out to us. I'll just share some information as we wrap up for this evening. So the Waypoint Talk series is an ongoing series we have with within the Waypoint Research Institute and Waypoint as an organization. We offer a number of different formats to our presentations, and we would certainly encourage you, if you found this one to be interesting and you're wanting to learn more about the other offerings that we'll have throughout the year, I encourage you to reach out and join our mailing list so that we can keep you up to date. Following today's session, we will be sharing an email containing a post-event survey. We would love to have your feedback on this session, but also to see what other topics may be of interest to you going forward. And in addition to that, as I noted at the beginning, we have recorded this session, so we are hoping that you will be able to watch again, or certainly share with your colleagues or friends that may not have had the opportunity to join us tonight. You'll see at the bottom, we do have a link here to connect with us via email if you do have additional questions, whether it's around tonight's presentation or other upcoming events. So with that, I thank you all for spending your time with us this evening, and I hope you all have a wonderful evening. Thank you.